So we know that diabetes is one of the most common non-communicable diseases. Cardiovascular disease is the most common cause of death. The management of cardiovascular disease in diabetes is of great challenge for the physicians and the cardiologists. So we know from the International Diabetes Foundation, published in 2021, that approximately 537 million adults are living with diabetes. The total number of people living with diabetes is projected to rise to 634 million by 2030 and 883 million by 2045. Almost 1 in 2 adults are living with undiagnosed diabetes. Diabetes caused 6.7 million deaths, and 541 million adults have impaired glucose tolerance, which places them at an increased risk of developing type 2 diabetes. Just in Europe, 1 in 12 adults are living with diabetes, and the numbers are going to rise. We have 1.1 million deaths due to diabetes in 2021. The natural history of diabetes is already known, but as you can see in this slide, you see that the microvascular and macrovascular complications start long before the diagnosis of diabetes is made. And this is a problem, and we know from papers that both pre-diabetic conditions also increase the risk of cardiovascular disease. So the risk of cardiovascular events and death increase in people that have already established diabetes and cardiovascular disease. Also, we can see here that people with diabetes and cardiovascular disease live 12 years less than people that had no diabetes, and people that have diabetes were 6 years less. Also, it's a known fact from UKPDS that the higher the glycosylated hemoglobin, the higher the increase for the risk of cardiovascular disease. We found out that the distribution of the initial presentation of cardiovascular disease, heart failure, had the second place after peripheral arterial disease. So heart failure has a lot of people which present as the first symptom for cardiovascular disease in diabetic people. And this is a problem because these people are at risk for morbid and fatal events. And heart failure are estimated to affect more than 64 million people worldwide. The heart failure morbidity and mortality rates are high despite the advances in therapy. And only in the US, the 5-year heart failure mortality after the diagnosis is around 50%. Heart failure classified with different phenotypes according to left ventricle ejection fraction. So we have heart failure with reduced ejection fraction when the ejection fraction is less than 40%, with mild reduced ejection fraction when it's between 41 and 49, and with preserved ejection fraction when it's above 50. The guidelines up to a few years were RAS inhibition, beta blockades, and mineralocorticoid reception inhibition. Things are not the same anymore. According to the Cardiovascular Disease and Risk Management in the Standards of Care in Diabetes in 2024, heart failure is another major cause of morbidity and mortality from cardiovascular disease. Studies have found that rates of incident heart failure hospitalization were twofold higher in patients with diabetes compared with those without. And we have all kinds of heart failure, both with preserved ejection fraction and with reduced ejection fraction. Also, for prevention and management of both the cardiovascular and heart failure risk factors should be systematically assessed at least annually in all patients with diabetes. And of course, we have to include the obesity, the hypertension, dyslipidemia, smoking, family history of premature coronary disease, chronic kidney disease, and the presence of albuminuria. So this is the reduction in diabetes complication. We have to the treatment for the glycemic management, the blood pressure, the lipids, and we have to include agents with proven cardiovascular and kidney benefits. Let's see what the guidelines say. As for metformin, restriction to use of metformin in patients with medically treated heart failure were removed by the FDA in 2006. Observational studies of patients with type 2 diabetes and heart failure suggest that metformin users have better outcomes than patients treated with other anti-hyperglycemic agents. However, no randomized trial of metformin therapy has been conducted in patients with heart failure. Metformin may be used for the management of hyperglycemia in patients with stable heart failure as long as kidney function remains within the recommended range for use. Also, patients already prescribed metformin, SGLT2 inhibitors, or GLP agonists should be added independent of the need for additional glucose control. Patients with type 2 diabetes and atherosclerotic cardiovascular disease not treated with metformin, an SGLT2 inhibitor or a GLP should be given first line, and metformin should be considered for those thereafter warrant additional glucose control. Sulfonylureas. Given the lack of data of any demonstrable benefit, sulfonylureas are not recommended as initial therapy in patients with stage 3 of heart failure with reduced ejection fraction. Based on findings of statistical non-inferiority of linagliptide versus placebo in Carmelina, coupled with non-inferiority of linagliptin versus glimepiride in Carolina, one might conclude that glimepiride is more likely not different for placebo with regards to cardiovascular safety. Thus, the long-lasting uncertainty about the cardiovascular safety of sulfonylureas may no longer be clinically relevant for glimepiride, at least in patients with a shorter duration of diabetes, like those enrolled in the Carolina trial, that they had 6 years median duration of diabetes. Thioglitazones. Data on the effect of the glucose-lowering agents on heart failure outcomes have demonstrated that thioglitazones have a strong and consistent relationship with increased risk of heart failure. Therefore, thioglitazones should not be used and should be avoided in patients with symptomatic heart failure. Thioglitazones increase the risk of heart failure with the increment in risk of heart failure with pioglitazone at an estimated 0.4 annualized. Absolute increase heart failure associated with thioglitazones appears to be attributable to the expanded plasma volume. So patients with type 2 diabetes should not be treated with thioglitazone and heart failure, DPP-4. Recent studies examining the relationship between DPP-4 inhibitors and heart failure have mixed results. The successful assessment of vascular outcomes recorded in patients with diabetes mellitus, thrombolysis in myocardial infarction, 43, the SAVOR TMI, showed that patients treated with a DPP-4 inhibitor saxagliptin were more likely to be hospitalized for heart failure than those given placebo. However, the other 3 cardiovascular outcome trials, the EXAMINE, TECOS, and Carmelina, did not find a significant increase in risk of heart failure hospitalization with those DPP-4 used. The GLP-1 receptor agonist. No increased risk of hospitalization for heart failure has been reported with GLP agonists in the meta-analysis of phase 2 and 3 trials, demonstrating the safety of this pharmacological class, and such findings have been confirmed by 3 large prospective cardiovascular outcome trials, the ELIXA, the LEADER, SUSTAIN-6. In particular, in the LEADER, reported a trend towards a reduction in heart failure hospitalization, together with a significant reduction in cardiovascular and all-cause mortality in patients with type 2 diabetes at risk for cardiovascular disease. Semaglutide, in this quite recent article, the trial showed that patients with heart failure with preserved ejection fraction and obesity, treatment with 2.4 milligrams of semaglutide led to a larger reduction in symptoms and physical limitations, greater improvement in exercise function, and greater weight loss than placebo. For insulin, patients with established heart failure, there is little evidence about the safety and efficacy of insulin use. There are no RCTs for the use of insulin. The Origin trial saw no impact of basal insulin glargine on cardiovascular outcomes and heart failure events in patients with cardiovascular risk factors in comparison to standard of care. Given insulin's correlation with hypoglycemia and weight gain and lack of demonstrable cardiovascular benefits with use, other agents such as metformin or SGLT2 inhibitors should be preferentially, unless we have appropriate glycemic control cannot be achieved solely by those agents, and then we have to add insulin. And we come to the last category of drugs, the SGLT2 inhibitors, that they constitute a key treatment to the reduce of cardiovascular disease and heart failure outcomes in people with diabetes. There were a lot of trials, the first one with EMBAREG study, which showed a reduction in 3-point composite MACE of 38%. Then we had the Canvas program with canagliflozin, which was reported to demonstrate superiority for 3-point raise for MACE, and the subsequent credence trial. Declare TMI, the trial for dapagliflozin, which also showed a non-significant reduction in the rate of the 3-point MACE and a significant rate in heart failure hospitalization. We had the DAPA-HF study that they saw a significant relative risk reduction versus the placebo. Also, the Emperor Reduce, which also we had the reduction in the 3-point MACE and hospitalization and the kidney function. So, bottom lines, SGLT2 inhibitors for heart failure with the reduced ejection fraction, they proved to have a 13% reduction in all-cause death, 14% reduction in cardiovascular death, and 26% reduction in heart failure hospitalizations. And then we had the PRESERVE study, the Emperor PRESERVE, for heart failure with preserved ejection fraction using epagliflozin, which also was confirmatory for the composite primary endpoint, the 3-point MACE, as you can see here, for rehospitalization of heart failure, the kidneys. We have for dapagliflozin a multi-center in USA that showed that treatment leads to significant improvement in both symptoms and physical limitation, as well as objective measures of exercise function in patients with preserved ejection fraction heart failure. And then we had the DELIVER program, which also proved that. Again, the same. You saw that the dapagliflozin has reduced in all range of heart failure. The Impulse trial, a step forward, when they started using the inpatients when they're hospitalized immediately, start using epagliflozin, which was designed for the acute heart failure. And the conclusions were that patients hospitalized for acute heart failure were 36% more likely to experience a clinical benefit. It was consistent with all ranges of heart failure and was well tolerated with overall. And here, well, it's not a actually diabetes drug, but it's a new category that we have to address, the finerenone, the Fidelio and Figaro trials that also saw reduced in the heart failure hospitalization, and all the primary outcomes of death were good. So there are now 4 foundation therapies for the treatment of heart failure: the beta blocker, the SGLT2, the ACE ARNI drugs, and the MRAs. What are the key physiological effects of the SGLT2 inhibition? They cause the increased glycosuria, and that's the way that they decrease the glycosylated hemoglobin. They decrease the glycotoxicity and the body weight. They increase the natriuresis and the osmotic diuresis, so they lower the plasma volume, lowering the interstitial fluid. They have a small effect, lowering a little bit the blood pressure, and they lower the glomerular filtration. So these they're different from the classic diuretic effects from the diuretic hypertensive class drugs, because they selectively reduce interstitial volume with minimal changes in blood volume. They have counter-regulatory stimulation of the RAS and no activation of the sympathetic nervous system. They do not cause hypokalemia. They improve the renal function, and also they reduce the uric acid levels. That's why SGLT2 inhibitors and the proposed mechanisms of action for the heart failure benefit include decreased pre and afterload, improvement in cardiac metabolism, the myocardial pump and potassium hydrogen exchange inhibition, decreased cardiac fibrosis, and decreased inflammation of epicardial adipose tissue. That's why in the holistic approach, as Professor Hadjiangelakis said before, these patients need the first to address the cardiometabolic, the cardiorenal problems, and include drugs that have cardiorenal benefits for those patients. As you can see in the 2024, heart failure has SGLT2 with heart failure benefits. We suggest to avoid thioglitazones, avoid saxagliptin, and if not glycosylated is not in target, then we can add either a GLP, long or short acting. Thank you. And I conclude with a slide a photograph that I took exactly 1 year to this day, where I was visiting Canada. And that's